So good morning, everybody. My name is Annelies, and I work in Ergo as a clinical research nurse, and I just do a little presentation about what a research nurse is about and how I got here after quite a few years being a nurse. So being a clinical research nurse is easy. It's just like riding a bike. That's what lots of people think. Let's see if that's true. So a little bit about my background. I'll talk you through what is my role. The UK PHRST, or the Public Health Rapid Support Team, as I work for now at the moment. I'll go a little bit in that. My current projects and my trials, the current challenges which come in this role as well, and overall research nurse challenges. So if I talk to you a little bit about my background, I qualified in 1990 in the Netherlands, in the south, in a very tiny little district hospital, where we literally treated everything. We had HIV, we had malaria, we had Alzheimer's, oncology, lots of drug users, lots of alcoholics, all in one ward. And we had some acute cardiacs and ear, nose and throat operations and everything. So as you can imagine, I learned to look broad. I learned to plan ahead. We had a small team with lots of patients. So one of the qualities I have now, I think, is the planning ahead and making sure that I look beyond what needs to be done. And that's all what I learned literally in my little tiny hospital in the south. After 12 and a half years there, I moved to England. I wanted to work for the Médecins Sans Frontières, but we needed to do the tropical diseases for nursing, and I could do that only in London. But then when I was in London, I liked it a bit too much. So the 1 year became 2 years and became 3 years, and it's now 20 years coming in January. I don't think I will go back. I had a really interesting career. I got promoted quite quickly to sister and then sister manager on a really busy oncology ward in London, and after 5.5 years, I moved into research nursing in a very busy hospital, again, the UCLH in London, which was at that time still a bunch of hospitals of 1700s, 1800s, full with mice and cockroaches. Not very nice. But now they've built this beautiful new hospital, and also later on a new outpatients building with air conditioning, which was something we did not have, of course, in the old buildings. So we still had placards on the window saying, please don't throw your cigarette butts out of the window. That's how old it all was. Can you imagine? You walk on the street and you get pelted by cigarettes. So yeah, it was a really nice a really nice time there. And I worked there for 12.5 years. Literally started with four or five little clinical trials, and we built it up to, when I left, we had something like 35 or 38 trials I was working on. Not all of them open, but all of them in setup. So you had to do a lot of paperwork. The ones that were open, or they were still having active patients and follow-up, it was a busy time. And again, I use my skills from Holland there. So when you have a clinic and you have more than 25 patients, you need to look ahead, you need to plan ahead. You need to be able to come in a clinic and sit there, twist your thumb, waiting for your first patient. If you still need to do a lot, then you haven't prepped your clinic very well. So that was one of the things I learned and practiced more and more. And with so many trials, you need to be on the ball. We had also a lot of doctors, and you can imagine if you're on your own and you've got 10 doctors pulling your ear saying, I need a patient information sheet for this trial. I need a patient information sheet for that trial. It becomes quite chaotic at one point. So then in 2014, of course, the Ebola crisis started to appear, and I volunteered for the UK Med. But they only wanted people from emergency rooms and ICU, so I missed that first round. And then got approached in February by Gail Carson, That was a research project here done by the Oxford University for Ebola called the Rapide Trial for TKM, which is a medication we would give to Ebola patients in the red zone. So I volunteered for that, and they were very happy to have me, so I was really pleased, and I managed to get some time off from work. So I had a really great time there. Again, it was busy, it was booming, harsh conditions. You can just picture yourself in the heat, in a tent, having the suits on, having the pressure that you need to do certain things in certain small time. So it was really good. I really enjoyed that. And then about 1.5 years later, 2 years later down the line, I got approached to do this job I'm doing now. So I started mid-July this year in my new role as a clinical research nurse for Ergo. On top of that, I will also look after the clinical research in the rapid support team, if there are any. So that's a little bit my background. 31 years of nursing, so it's a hell of a lot of time. This is me in Sierra Leone. I'm in the green zone. I'm passing medication over the nobody's land, no one's land literally, which is the table. And where the chap stands in the suits, that is the red zone. So that is contamination zone. So we don't hand stuff over because, of course, you can touch his glove and then you become contaminated. We just had a broomstick and a table. Worked really well. And of course, every time you did anything, you would use the alcohol gel on the table and still do your hand hygiene in case somebody else touched the broom from the other side. So you would always play it safe. Those are the tents where we treated the patients in. I think you've seen all these pictures in the news. Of course, we couldn't take anything out of the red zone. So this is how we recorded all the consent forms, all the daily activities like blood pressure forms. We would fill it in on a form in the tents. And then at the end of the day, we would put somebody in the red zone, would put them on the clipboard, and we would just have a camera where we would zoom in maximum and take photographs of a consent form or the blood pressure forms and everything. Then we would print those out, and that would be our source documents. Everything in the red zone would get burned and nothing comes out. And it worked quite well. So as you can see, it was a nice thing to do at the end of the day. So my current role at the moment and my main duties is coordinating and managing the nursing support for clinical research studies in Ergo. Also ensure that the safe welfare for the participating subjects, support the colleagues in their work, because we work as a team, when setting up clinical trials, and support the day-to-day clinical and administrative aspects of clinical research, of clinical studies. So it's a lot of paperwork, a lot of gathering stuff together, making sure that everything is done via good clinical practice. So that's one of my roles, that everything is followed according to the rules. In case we will get inspections, and they're always looming around, there's so many times where you can have inspections now. You need to be prepared. So again, you need to look ahead. If you start preparing when you get an inspection announced, you're too late. You run out of time. So one of the bits of my role is that we do everything according to the rules. And in emergency settings, rules are something that is thrown out easily out of the window. So it can be challenging to make sure that everybody follows the same rules. We have a good team. I haven't had to pull anybody's ear yet, so really pleased with that. So UK Public Health Rapid Support Team is something that was set up. So the Department of Health set up a partnership between Public Health of England and an academic partner, which is the London School of Hygiene. They won the bid in partnership with the University of Oxford and King's College. So the UK Public Health Rapid Support Team is part of the UK offer to the ODA, the official, I've forgotten now, official development assistance, thank you very much, which are the low and middle income countries. Support where the support is needed so we can rapidly respond to and investigate outbreaks with the potential to prevent them from becoming significant public health events. It's quite a sentence there. So low and middle income countries, so we don't really do anything in Europe. Their government, if there is a problem somewhere, their governments can then put a request in with our government, and then our government decides if we put our team in or not. So our team has already been out a few times, and one of them was with the mudslides in Sierra Leone, where they did a fantastic job. So I don't need to go there. There was no research project, but the team, we have a core team of about 8 people, and some of them were sent out and prevented there a potential cholera or any waterborne diseases outbreak. So they did a really good job. So the deployment, the UK PHRST will rapidly deploy on behalf of the UK government, either, and it could be with the WHO as part of the GORN network, the Global Outbreak Alert and Response Network. And that is happening at the moment in Madagascar. They are there with the WHO, sorting the situation out, assessing it. They can also go bilaterally as a standing team with multidisciplinary public health professionals and researchers as required in countries that are a priority for the UK's ODA programme. So it depends a little bit. There's 2 ways they can be deployed. My current projects, very far from my 35 or 38 trials that I was doing last year, or well, before July. I have 2 at the moment, so it's quite nice. It looks really like I might be twisting my thumbs, but it still keeps me quite busy. At the moment, we're trying to set up a phase 2 PK favipiravir trial. And that is in the combination of favipiravir with oseltamivir in severe influenza in China. We wanted to set up something for bird flu, but the bird flu cases are too spread out. You can imagine China is a huge country. There are lots of cases, but still not enough cases in every hospital to say we can just put up a bird flu trial. So we decided to go for the severe influenza. We will still gather all the information for those severe bird flu patients, but we also get the H1N1, the H5N1, the H5N6, and there's even more out there. So in Oxford, in September, we had a delegation from China coming over to us, and they stayed there with us for about 10 days. They've set up the protocol with them, created patient information sheets, went through all the paperwork that they needed, we were developing electronic case report forms, log forms, and especially training needs, because there's a lot of training that China still needs. Our visit in Beijing was in October, which was lovely. We went there for a week and we reviewed everything again, and we did lots and lots of training. The Chinese team is a very dedicated team, and there was a professor, Bin Chao, who was a lovely man, and he was thanking us constantly for all our input, which is nice to hear. So I think we're nearly ready to set it up. We're waiting for them to do all the approvals. Of course, I can't do that from my side. That needs to go from China, and it will go to the China FDA. And as you can imagine, there is a bird flu potential pandemic outbreak. There's a lot of talk about that. They are very worried. Of course, we don't know what will happen in the future and if it will happen in China or anywhere else in the world. But people are quite worried about bird flu. And there's a lot of birds, of course, in China. So these are the ducks. We had some lovely Peking duck as well there. I can recommend that anytime. So my other project was the plague observational study in Madagascar. So our team has been helping out there since the beginning of the outbreak with the WHO. We developed pretty much over a weekend the patient information sheets and all the protocols and the case report forms as a team. Everybody really chipped in. My role was in the first instance to set up the SOP, Standard Operating Procedure forms, and help Emmanuel with the OXTRAC approvals, but then Oxford decided not to be the sponsor anymore, and I ended up doing nothing, which was also quite nice. So I was supposed to manage the nursing aspects of this trial, but now it's all taken over by Madagascar. So they're doing the approvals and they're putting all the forms together. So I think my project will wane off a little bit in the distance now. And as you know, the plague outbreak is still going on. There's about 2,000 cases. And we hope to get a little bit more background from our observational trial, why these people are having all these symptoms, but they're not very severe. So we hope we get a lot of data back from it. There's no treatment trial because, as we know, antibiotics work quite well with plague. So it's just to see what is happening. Current challenges. As you can imagine, in China, it was the language. Everything needed to be translated from Chinese into English and vice versa. China also has quite limited research experience, at least the team we were working with. They've heard of GCP, but it's not there completely. Also, they assume that we have all the paperwork ready like that. So we literally helped them out with all the paperwork and literally showed them that everything needs to be adapted per trial. There are no standard forms in research. Everything needs to be adapted. In Madagascar, of course, everything we need to be translated in French and back. We have a few very good translators in our team who've been busy over the weekend. And the government also was in the beginning very, very overwhelmed with this outbreak. So it was difficult for us to get them to look at our project. There was quite a bit of a delay in that bit. But it seems to be going well now. Positive notes. In China, we had a lovely team there, as I said. The professor was great. He had a very young team under him, very dedicated. If they would have let us, if we would have let them, we would have been there from 8 till 8 probably every day. Because that's how they work there. They just start at 8 and they work forever. They have 4 o'clock meetings, Peter. 4 a.m. meetings, and the professor is there. He doesn't delegate that to his team. He has meetings at 4 o'clock in the night. I mean, they are dedicated, these men. But very lovely to work with.
That's what we expect from us.
I found that the English in the team was very good, and what they did not know, it was all Googleable, so we managed to have a good conversation in both ways, and they really want to make this trial a success. It's lovely. There's a lot of training we've thrown at them, and they've taken it in very good. So lovely to work with. Research nurse challenges. Overall, people often don't really fully understand the complexes and the challenges of this exciting and rewarding role. Being a research nurse requires a balancing of a whole range of diverse responsibilities. So we are educators, advocates, caregivers, decision makers, secretaries, counsellors, and don't forget the pack horses, and sometimes all at once. In my old job, if you saw me going to the clinic, I had a big suitcase, and I had a bag on top of that. I had a backpack and often a plastic bag. And that is to get all the lab kits to my outpatients clinic. That was a 10-minute walk. So I have to go through over the London streets with all the traffic that try to kill you all times. Very challenging. You look after the patients. You're not just there to give them the patient information sheet and to make sure that they understand the trial. You're there to say, hey, you're not looking well, or how is your wife, or how is your child? You've just been having a grandson. It's the whole package. And I think that is important, that you build up a good relationship with your patients. And if they trust you, they will do a lot for you. You get so much more out of them than when you just say, sign the consent form, and if you don't want to do the trial, that's fine. That's not what we are. We are there to guide them through the whole process. So when they're on the trial, when they're off the trial, but also sometimes when they're dying, you're there still. And it's important that you keep that going on. So busy job. I often got phone calls at home, which is fine. I worked with cancer before, so sometimes you build patients up over 8, 9, 10 years. In this job, it will be different. So I hopefully won't have any phone calls at home anymore, but we'll see. Often colleagues in different settings don't see us in action. So therefore, they might think we drink cups of tea, cups of coffee, and we don't do much. Often I invite people in my clinics in the past when I had the feeling that they were thinking we would do nothing. And then one clinic made them change their mind completely. So we're not always there also to provide patients in the traditional ward settings, but we will constantly use our nursing skills and our expertise. Like bloods taken, cannulation, you name it. We pretty much do everything in the clinics. And in outbreak settings, we will be there working with the patients in tents or wherever in treatment centers. So we are still there. We also need to recruit patients. And as research nurses, we implement innovation and effective recruitment strategies. Time management, I'll come back to that again, is one of our first skills as a successful research nurse needs to acquire. So plan ahead and we will save so much time. We all work on different studies at once and have a number of patients on one study at any one time. Challenging accompanying paperwork, whether paper or electronic. As you know, research is killing forests, trees, forests. These days, things are getting more electronic, but we still need paper signatures often as source documentation. So, unfortunately, we're still killing trees by the bunch. Various educational requirements are needed as we need to keep up with everything. GCP requirements, but also our nursing requirements. So there's always a lot of e-learning and face-to-face learning. So at the end, being a clinical research nurse is easy. It's just like riding a bike, except the bike is on fire, you're on fire, everything is on fire, and you're pretty much in hell. Thank you very much.
Thank you so much, Annelies. That was great. Sorry, I don't hear my voice on.